I'm going to talk about the work of the Bexley CAMHS adolescent team over the first 18 months of our practice. And we're a team that's specifically being set up to try and reduce adolescent inpatient admissions. And the plan of what I'm going to talk to you about, I'm going to say a little bit about why we would want to reduce inpatient admissions for adolescents, tell you a little bit about our team, tell you about the goals that we have set for us by our commissioners, which are called key performance indicators, about why we've chosen to use a mentalisation-based approach, about our client group and our achievements over that first 18 months, about what we struggle with, both in terms of meeting our KPIs and in terms of using AMBIT, and how we think AMBIT has helped us achieve our goals so far. So in terms of why would we want to reduce adolescent inpatient admissions, inpatient admissions can often be traumatic for young people. They're dislocated from their family and from their normal developmental pathway. They are subject to the very adverse effects of being on an inpatient unit with lots of other young people who have some quite difficult problems. It can reinforce the belief that they or their problems are not manageable by people, that they need to be got rid of and handed over to somebody else. And they can become institutionalised, and it can become very difficult for them to return to their community. There's also a growing body of evidence that actually community alternatives can be equally effective, if not more effective, as inpatient admissions in terms of outcomes, and that young people and their families prefer to be treated in the community than to go into hospital. There's also a high use of inpatient services has resulted in significant increases in public spending, and that's particularly true for the trust where we work, where there is no adolescent inpatient unit in the trust, and so we have to purchase it from other trusts, either locally or actually sometimes nationally, and so we're paying quite a high cost every time we need to admit somebody. So in 2010, Bexley CAMHS put in a bid to set up a new adolescent service that would focus particularly on looking after young people who may need admission but in the community. And it was successful, and so we have a new multidisciplinary team that includes this range of professions, so nursing, psychiatry, psychology, psychotherapy, occupational therapy and family therapy. It's 9.55 whole-time equivalents, it was over the period that I'm talking about. We've actually recently just had an increase in funding. There are also 2 substance misuse workers who I've not included in this because they're funded separately and they have their own set of KPIs, which would be a whole other presentation for them, so I'm not going to try to address that as well. And our eligibility criteria is severe mental health problems, high risk of admission, high risk of suicide, high risk of violence, a history of disengaging with services, dual diagnosis, or a Community Mental Health Act treatment order. So we're talking about very, very high risk young people in terms of mental health problems. And our key performance indicators set by our commissioners are to decrease the use of adolescent inpatient services, and that's counted in terms of the number of bed days, so that's literally how many days have we had somebody in a bed on an inpatient unit, the number of young people who are admitted, the length of their stay, the number of admissions each young person has, and the spending on admissions. To provide a rapid response, in-reach to young people who are inpatient and outreach to young people who are not engaging with services. To provide access to psychological therapies, access to psychiatric treatment in the community, intensive treatment, access to occupational therapy and access to group work. So it's an outreach service, but it's also a therapeutic service. We're being asked to provide both. And to demonstrate that we are clinically effective and that we are looking at patient satisfaction and participation. So the reason why we chose a mentalisation-based approach is that we needed a model which made use of all the team members' skills, and we have a wide range of team members, so we needed something that wasn't just going to use some of the team members' skills and not others, that could include everybody. We needed a model that could help us think both about the outreach work but also about treatment as well, so that could actually cover both of those. And mentalisation is an evidence-based approach for young people who at the time of the business case were those who were being most frequently admitted. And those were young people who were suicidal, so 66% of the young people being admitted at the time of the business case were admitted because they were suicidal, and 30% of them had a diagnosis of emerging personality disorder. So that was the highest diagnosis, most common diagnosis at that time. So that's why we chose a mentalisation-based approach. The way that we use mentalisation in the service is we think about AMBIT as being the approach of the whole team and the approach that we use in outreach. But we also offer an intensive treatment programme, which is a mentalisation-based therapy for adolescents, which includes individual, group and family work. We also have group work, which is not mentalisation based specifically, and we have a whole range of other evidence-based treatments, which on this diagram looks like it's just part of the work, and actually is a very, very large part of the work. So the first 18 months of our practice, the people that we've worked with, we've had, in the first year, we've worked with 184 young people. And in the second 6 months, it was 122, and some of those will be the same, so they would have gone across the whole 18 months. But quite a few of them will probably be the same young people. They're largely female, with an age ranging from 12 to 18, with an average age of 16 or 17, so they tend to be slightly older adolescents. They're largely white British, but not exclusively. And the most common reasons that we are working with them are self-harm, depression, family problems, and suicidal thoughts. And that has remained quite consistent across that 18 months. They have an average of 3 problems each of these young people, so then they don't tend to have just one problem, they tend to have problems in a number of areas. And the range is from actually 1 to 16. So we have some young people who have a very, very complex set of difficulties they're struggling with. A significant proportion of them are NEET, and NEET is, for those who don't know, neither education, employment or training. So they're unoccupied during the day. That has gone down slightly in the second part of in the last 6 months, that I'm looking at. We're not quite sure whether that might be an effect of our service, or whether that might be to do something with the education department is doing. We can't claim credit for that. But and there's also nearly a quarter of them have unmet social and environmental needs. So in terms of our achievements so far, in the first year, 100%, in the first 18 months, 100% received in-reach. We've got between 18 and 22% getting outreach, around 80% having psychological therapy, 70%, between 66 and 77 having psychiatric treatment, between 15 and 19 occupational therapy. We've had 3 groups running with just under 10% of the young people attending those groups. And between 13 and 80% have been seen intensively, and intensively is at least twice a week, every week. That's how we count intensively. In terms of a rapid response, it's taken us a while to get our measuring up to speed with that. So for the first year, we were just measuring that they were a little bit more than 2 weeks. In the last 6 months, we were looking in a bit more detail. So emergencies have been seen on the same day. Urgent cases are seen within 3 working days. And what we call routine, which is what is routine for our team, rather than routine in general, are seen with an average of 8 working days, and never wait longer than 3 weeks. So these are the kind of the really significant findings, I think. So this is about decreasing the use of inpatient services. So this first column here is from the business case, and this is the year that there was the highest number of admissions with the point at which we submitted the business case. So it's 2008, 2009, and at that point there were 2,715 inpatient bed days used that year. This was the lowest year on the business case, so it was 1,147, and this is the average across the years counted in the business case, 2,421. So in our first year of working, we had 1,491 bed days that we actually used. So we are slightly higher than the lowest year, but considerably lower than the average year in our first year of practice. The purple there is the days that we estimated we would have used if we hadn't been there available. So young people who had a crisis that would have required an admission if they hadn't had access to our service. And that is an additional 1,158 days. So as you can see, that would have brought us up to the highest year. This last column is the first 6 months of the last financial year that we've just finished. So in the first 6 months, we had 671 days. And again, we put the estimated days on top. Unfortunately, this conference is just the wrong side of our annual report. So I'm in the process of writing our annual report, so I haven't got all the data for the full year. What I do know is that actually our bed days for the full year is 733. So we've actually halved the year before. I'll come to the money in a minute. I've got the money as well. We don't have any information about lengths of stay prior to our service existing. That wasn't collected. So I only have that since our service has been in existence. So our minimum stay in the first year was 41 days. In the next 6 months, it was 7 days, and that's a reduction of 82%. In the first year, our maximum stay was 351. That went down to 232, and that's a reduction of 34%. And our average stay went down from 122 to 76, which is a reduction of 38%. So here comes the money. So the columns are the same as on the previous bar chart. So this is the highest year, 1,000,007. I'm not even trying to give you the whole number. This is the lowest year. This is the average year. This is our first year of practice in terms of what was spent. There's no adjustment here made for inflation, I should say. So some of the increase will be because of inflation as well. And this is the estimated saving. And this was our first 6 months and our estimated saving for that first 6 months. So again, this will have only gone up very slightly because of the bed days.
Can I just ask whether the actual spending includes the cost of your new team?
It doesn't, no. No, it doesn't. This is the saving on bed days. It's not the cost of our team, so I haven't included that. I am planning to work that out for this annual report, but like I said, slightly the wrong side of the annual reports. So in terms of clinical effectiveness, our clinical effectiveness is measured by CORK. For anybody who doesn't know, CORK is a national research process where over 70 NHS trusts and some international healthcare providers submit data about their outcomes, and are compared with each other and compared with clinical outcomes based on the measures that they're using. So this is for Bexley CAMHS as a whole, not just the adolescent team. The adolescent team's figures aren't high enough for them to actually look at whether we've achieved anything significant. The measures are taken at initial assessment, which is time 1, and then again 6 months later. And Bexley CAMHS as a whole shows significant improvement across all of the measures between time 1 and time 2. I'm not going to give you all of the measures because again that would be a whole presentation in itself. I'm just going to give you an example. So this is the Strengths and Difficulties questionnaire for parents. This is time 1. The purple here is for the whole of Cork. So this is all of the trusts participating in Cork. The red line is the clinical cut-off. And the yellow there is Bexley CAMHS. So we've gone from above the clinical cut-off to below the clinical cut-off, and also we've dropped more than the whole of Cork. And similarly for the SDQ for young people, same kind of finding. In terms of patient participation and satisfaction, we have 2 participation activities that have been running. The first is a newsletter group where young people from the adolescent team have written a newsletter for other people coming to CAMHS. And the other is that we have had a project with Young Minds where young people coming to Bexley CAMHS and also one of the other CAMHS teams in Oxley's have got together and made a film for young people who are being referred to CAMHS about what it's like, which is going to be put on our website. I was hoping I might be able to show you a bit of it, but it hasn't actually gone on the website yet, so I can't, I'm afraid. And in terms of patient satisfaction, that's also measured by Cork using something called the CHI-ESC. And again, this is for the whole of Oxley's actually, so this is all of the CAMHS teams in Oxley's. There wasn't enough figures to separate out all the different services. But Oxley's is rated significantly higher than the rest of Cork on all these 10 items in terms of patient satisfaction. And parents also rated Oxley's higher than the rest of Cork on these 11 items. So the things that we struggle with, in terms of meeting our KPIs, we struggle with very high caseloads. The caseload is probably 50 to 30% higher than actually it's intended to be when the business case was put in. We have multiple inpatient service providers over a very wide geographical area, and that makes it difficult to form relationships with staff. It makes it difficult to explain our approach to them and for them to hold that in mind and for them to get to know us, because sometimes we might admit somebody to one unit and then maybe not use them again for a year, so they have no more contact with us in the meantime. And the other Bexley CAMHS teams with whom we work haven't had this input of resources and so are very overwhelmed, which makes it very difficult to move young people between teams who actually no longer lead the intensity of the service that we're providing, which adds to the high caseload. In terms of AMBIT, what we struggle with is manualising. Until very recently, we didn't have full access to the manual because of the complications of the NHS IT system. And that's made it very difficult to get familiar with the manual. And we also have mixed views in the team about the usefulness of the manual. So some of us are more positive about it and other of us are less positive about it. The high caseload has also meant that having time to pay attention to when we're using AMBIT has been challenging. And when we were thinking about today, what we were thinking is that the formal parts can therefore get lost. That doesn't mean that we're not using them, but we think we tend to use it a lot implicitly rather than explicitly. And one of our learning increments that we've had recently is that for new members of staff, that can be quite de-skilling, because if we're using it implicitly, they don't realise that's what we're doing. How has AMBIT helped us? I think it's helped us think a lot about the impact of attachment on young people's engagement with us. It's not always possible for us to actually implement that, because when young people need several contacts a week and we have part-time workers, it's not always possible for us to have a single worker with them. But we now think about it differently to perhaps we might have done, how we introduce people to them, how many people we have involved with any one person. It's helped us in terms of talking about the impact of emotion on thinking with young people and their families, and a way of explaining it to them, which is less mental health and more normalising. And also thinking about the impact of anxiety on our own ability to mentalise as professionals and as a team, and having understanding of each other and each other's struggles. It's given us permission as a team to think in a crisis, because there's a high expectation on us that if there's a crisis we will do something. We will do something to make the crisis go away, and it's given us permission to think first before we have to do something. We use the thinking together conversations quite a lot. We work in a big shared office. There's lots of conversations that happen, and that's become a way of helping us focus those conversations. And we also use the disintegration grid, both literally, and some of us have used it in things like consultations with schools, but also just holding it in mind as when we're thinking about how we're going to work with colleagues in other services and other teams, that's one of the ways that we try to think about what we're doing with them. We use it as a framework when we're stuck with a young person, when they're not engaging with us, how to go back and rethink what we're doing and re-engage them. And very helpful, the idea that just being curious is a goal in itself. Actually, we don't always have to know what to do, because again, there can be a high expectation on us, particularly from other services, that we will know what to do. And so to be able to be curious is very helpful. And the team find that it embraces everybody's expertise, so this diverse range of experienced professionals are able to come together, but also still be themselves. So we can still use our separate expertise, but also have some shared knowledge and some shared understanding.